is your surgeon? What is your
So my name is Josh Gossett. I'm the director for the Pediatric Transplant Center at Stanford Children's. And allow me to welcome you to our event today. Thank you so much for coming. We have, it looks like 84 participants currently in the window there. And so that's an amazing turnout. So thank you all for joining us. And I hope that you find the information helpful and that we can have a lot of good dialogue between all of you and our fantastic panel today. So I want to start us off by introducing our first speaker and panelist, Dr. Rachel Benson. Rachel? Oh, I think you're muted.
Hi, good afternoon. I'm Rachel Benson. I'm one of the liver physicians here at Stanford. It is an honor to have your time and attention to speak a little bit today about biliary atresia. So today I wanted to take just a few minutes and review some features of biliary atresia and then highlight a few elements of more recent research. And then after myself, Dr. Esquivel will talk a little bit more about treatment of biliary atresia. So starting from the beginning, just taking basics, thinking about the normal liver, as in this picture here. So there's bile ducts all throughout that collect bile, liquid that's important for helping to digest food, collect bile, and then bile comes out of the liver, hangs out in the gallbladder for some time, and then comes and is secreted then into the small intestine to help with food digestion. In biliary atresia, we have destruction or absence of bile ducts. There can be some variability in the different structures, but basically we don't see those normal bile ducts in gallbladder, and so the bile can't get out of the liver. And why does this happen? That's a great question. We still don't know. A number of studies have looked at a wide variety of different reasons why this occurs without being able to clearly answer this for us. We looked at viruses to see is there something about an infection that occurs while someone is pregnant or early in after birth, toxins, genetic factors, and immunologic factors, and it really has not been clear. Although there are a few candidate genes, but we know that genes in and of themselves are not enough, as we can see that when we have twins, one child can be affected and the other not. So knowing that even if they are identical twins, there's a difference in not both twins will have this condition. However, there are sometimes biliary atresia comes by itself without any other medical problems, or sometimes biliary atresia can come with a number of other medical conditions, in particular abnormalities of the spleen, heart defects, or things where organs can be positioned on opposite sides of the body. And in those conditions, when there's other medical problems at the same time, there's a greater likelihood of a genetic etiology. Taking a step back, what are the signs and symptoms of someone with biliary atresia? Early on, they can be quite subtle. So there's jaundice, yellow eyes, dark urine, pale stool. Dark urine comes from the elevated bilirubin levels and being excreted into the urine, and pale stools, it relates to the absence of bile going out from the liver into the intestines and then passing into the stool. There are some places where we have been doing a lot of work to find help with early diagnosis so that we can have early treatment and improved outcomes. This is a good example of a pale, we call acholic stools. This white stool on the top here, number 1. This is a stool color card used in Japan for screening. And you can see that this is given out and people are told to come back at a 1-month visit and talk to their doctor if they see about what their stool is like. Again, pale stools with no bile, and then yellow or green stools reflect the presence of bile there in the stool. Universal screening has been done in Japan and in Taiwan, and it has been studied and shown to be effective at helping to pick up biliary atresia early on to help with diagnosis. Some other strategies can also include routine direct bilirubin measurement in the newborn nursery. That's not been widely adopted, but some researchers at Texas Children's in Houston have been studying that strategy and have implemented it to screen also large numbers of babies and again help with early identification, because as we'll come to later, early treatment is very important. As many of you have been through, diagnostic workup, it can include blood work, imaging studies, in particular ultrasounds, a liver biopsy, and a cholangiogram, which is a study where dye can be put into the bile ducts to see if the bile ducts or gallbladder are formed normally. And their characteristic findings that we see in biliary atresia, elevated direct bilirubin, GGT, a small or absent gallbladder, liver biopsy showing some characteristic findings of bile ductular proliferation, and we call it ductular reaction, so changes around the bile ducts in the liver. And a cholangiogram is not able to highlight bile ducts in a gallbladder as we would otherwise expect it to. There have been some recent advances in helping us to identify biliary atresia with blood work. And this is an example of something that came out a few years ago, back in 2018, and now is finding its way into our routine practice with having a biomarker from the blood, which we call an MMP7, that we can send, and it's highly correlated with the presence or absence of biliary atresia. So if we do have an early baby with jaundice, we're able to help make that diagnosis also, again, more quickly. Another one of our important jobs is to consider what else can be causing jaundice in a baby. So we call cholestatic liver disease. It's a condition where we have elevated bilirubin and jaundice. Recognizing biliary atresia is the most common condition, accounts for about 40% of cholestatic liver disease, but the other 60% is a wide variety of other conditions, and it can include infections, illnesses in other parts of the body like the heart, medications, genetic disorders, and a wide variety of different conditions. More recently, we have advances in identifying genetic conditions. And for example, this is the number of genes that are tested on one of our gene panels that we can send to also, again, help us to exclude other conditions that can cause jaundice in babies. And just like to highlight this one, this was a gene for a new condition that was characterized here at Stanford a few years ago in some of our patients. We had siblings who both presented with jaundice and liver failure, which was not biliary atresia at the time. However, despite many advances identifying new genetic conditions, genes associated with them, genetic testing becoming a little bit faster, it can be difficult to obtain results of genetic testing in time to exclude biliary atresia and allow for timely treatment. Currently, there are quite a number of areas of research. As I mentioned, there's a lot of research about what is the cause of biliary atresia, which we call pathogenesis. What are strategies for early diagnosis, including things like stool cards or screening in the newborn nursery. There's also quite a bit of research about markers of disease progression. So thinking about who has biliary atresia, has had a Kasai, and has not had a transplant, how are they doing, and better ways to understand how we are moving forward, as well as long-term outcomes, and there as well, and understanding different types of interventions to help prevent progression of scarring of the liver. And I'll highlight one, which is looking at something called an IBAT inhibitor, which is an ileal bile acid transport inhibitor. And so this is a research study that we are a site participating in. And this is a potential therapeutic intervention after surgery. Again, I know I'm jumping a little bit ahead because Dr. Esquivel has not yet talked a little bit more about surgery, but wanted to highlight some newer innovations. So looking at this here, we have, there's bile from the liver, and after surgery, it drains into the intestine where the intestine has been connected up to the liver, and then it gets the bile gets reabsorbed, the bile acids, and then go back to the liver. And so a bile acid synthesis, reabsorption inhibitor reduces the reabsorption, acts on the intestines, reduces the reabsorption of bile, then can reduce overall the amount of bile in the liver and hopefully reduce fibrosis over time. So, and just one example of a study, this research study involves only children close to the time of their Kasai to really see what happens if intervening close to the time of surgery can help change outcomes going forward. So in summary, again, biliary atresia is characterized by fibrosis of the bile ducts. So we have impaired bile flow out of the liver, causes progressive scarring of the liver. Its cause remains unknown and research is ongoing to better understand its pathogenesis, better detect it, and better be able to treat our children with biliary atresia. Thank you very much.
Thank you, Rachel. Can you guys hear me? Okay, great. So I'm going to just go back a little bit and give my big welcome to everyone for coming. We actually have an international audience here. So thank you very much for coming to our webinar on biliary atresia from diagnosis to transplant. At Stanford Children's Health, we have over 30 years of treating patients with biliary atresia and transplant. Our family-centered care approach across the continuum of care allows patients and families to be part of the decision-making process. Our event today is in Spanish and English, and we apologize for any technical difficulties with our Spanish speakers, but we will make sure to follow up with any information that's required. Sarah Conlon, our transplant manager, is your contact person. We have both her phone and her email. If you have any questions and if you would like to be seen at our center, she can triage the information. We know how hard it is to navigate a medical center phone tree, so she'll be able to help you. And again, her phone and information are in the chat. The question and answer today will be at the end of the presentations. I know we are running short on time and respect of you giving of your time away from your family today, but we'll do our best. Also, I want to give a special thanks to our parents who are participating in our panel today for sharing their story, and a thank to Nancy Manalo-Smith for helping us. Our next speaker is Dr. Carlos O. Esquivel. He's Chief of the Division of Abdominal Transplant and President of the International Pediatric Transplant Association. Thank you, Dr. Esquivel.
I'm going to share the screen.
Great, thank you.
Let me know when
We're ready for you.
Okay. Takes a second.
Great, we can see it perfectly. Thanks.
All right. Well, thank you very much for the introduction. There is an echo, so if you folks can turn your microphone off, I won't hear the echo. Otherwise, it's going to be very difficult for me to give this short presentation. Thank you. Since we're running short on time, let me start by saying that the only effective treatment for biliary atresia in the current era is surgery. It's either the portoenterostomy, which is the Kasai operation, or a liver transplant. And so Dr. Benson already discussed the problem with biliary atresia, how the biliary system gets all scarred down, which is the outflow of the bile. And so what happens is that the bile gets backed up into the liver, and the bile basically digests the liver tissue in simple terms. And then the injured liver becomes really scarred, and that's what we know as cirrhosis, secondary biliary cirrhosis from the blockage of the bile ducts. So there was no treatment for these patients, these little kids, until the 1950s when Professor Morio Kasai, a creative Japanese surgeon, designed this operation that offered an opportunity for these kids to live. And so what he did was that he took a loop of intestine. Well, first he removed all the diseased bile ducts, and then he brought a loop of intestine and hooked up directly to the liver. So I don't know what happened. How come it went back to that? Okay, sorry about that. And that provides drainage of the bile into the intestine. And that's called the Kasai operation. Unfortunately, many of these patients eventually end up needing a liver transplant. So about the same time in the 60s, Dr. Starcell, Tom Starcell, and I was really fortunate to work with him for a few years. He is the pioneer in liver transplantation. And initially, many of his patients were the pediatric patients. In fact, many were children with biliary atresia because, again, you know, these kids had cirrhosis and they had no chance for survival. In fact, the first survivor after a liver transplant in the late 60s was a young kid, a 2-year-old, who survived about 2 years. And but that he showed for the first time that liver transplants can work. So in terms of the indications for liver transplantation, biliary atresia accounts for about 45% of all the cases we do, and that has not changed. You can see it in 3 different areas, and this is from the National Registry. The rate is somewhere around 44% of our cases are biliary atresia, and that's the same across the United States and abroad. So most of our patients with biliary atresia, they already have a scar, right? Because they had the scar for the Kasai. And so that's the same scar that we'd use for the liver transplant. Then what we do is we take the sick liver, which is really bumpy and lumpy and really hard, sometimes hard as a rock. And as you can see in the picture right at the top on the right, that's what a liver looks like, a liver of a child with biliary atresia. And then you can see the comparison with a new liver that is ready to be implanted. You know, the color, the consistency is completely different from that of a liver with from a biliary atresia. Then after we remove the sick liver, then we put the new liver in, and then we do the anastomosis, all the hookups, the veins, the inferior vena cava, the portal vein, the hepatic artery. The hepatic artery is very tiny in these young kids. Sometimes it's just 1 millimeter or 2 millimeters in diameter. The new liver comes with a new biliary system. And so what we do is we hook up the bile duct to the Kasai intestine. So, and that's the way we do it. And then what we do is we put a plastic tube that, and nowadays we bring it out to the outside. And what that plastic tube does is that it allows the tissue to heal around it, minimizing complications such as bile leaks or scarring that can lead to narrowing strictures, as we call them. So the biggest problem about liver transplantation is that, of course, we don't have enough organs to go around. So what we do is the first approach, and which I think is the best approach, is to see if there is a living donor. By experience and the experience worldwide, we know that the long-term outcomes with living donors are better than those with from deceased donors. And it's not surprising because, you know, usually it's a parent who donates, so they shared some of the 50% of the genes, right, with the child. So they have fewer problems with rejection long term. If we don't have a living donors, then we look at other options, how to get our biliary atresia patients transplanted. To me, the worst complication in a liver transplantation is to have a child die on the waiting list and not having that opportunity for a transplant and live a long life. Another possibility is using a split liver, where we can use part of the liver for the adult patient and the small part, which accounts for 20% of the liver for the child. And this picture illustrates that. Unfortunately, we cannot do that many split liver transplants in this country, and the problem is just the rules for organ allocation. So we have to approach the recipient, the potential recipient of the liver, which usually is an adult patient, and in this particular case, this recipient is a physician, and we asked him whether he was willing to donate that part of the liver he was going to get to this beautiful baby who was in dire need of a liver transplant. And he agreed, and you see the outcome was great. So if we look at the long-term outcomes on the right side, and we looked at about 25 years of experience, the outcomes are excellent. In our patient population, only 6% of the children required a second transplant. And the average length of stay is 18 days. And during the first year, the readmission rate is about 15%. So that's 1 out of 6 patients. And that's usually because they either have trouble eating, or they may have an episode of rejection or infection. That usually happens during the first year, and then they settle down. It's expected that at least 90% of the patients will live a very long life. And so this is our survival curve. And as you can see that the patients do really well. And although we have to give credit to the coordinators and the hepatologists, as well as the referring physicians, because they really keep a close eye on these kids, and they deserve all the credit. That's one of the reasons why our patients do so well for a long time, and we follow them for a long time until they become adults, and then they are referred to the adult team. So in terms of our recommendations is that we recommend that all infants with biliary atresia undergo a Kasai portoenterostomy. And the surgery should be done as soon as the diagnosis is made, ideally within 60 days of age. And this is because younger age at the time of the Kasai is associated with better outcomes. The jaundice will go away and the kids will thrive. If the child still has jaundice, the yellow eyes, for more than 3 months, or is not thriving, then the child should be referred to a transplant center. Unfortunately, the majority of the patients with Kasai operations will end up requiring a liver transplant. But many are able to maintain their native livers for a long time. In my own experience, the oldest patient who had a Kasai operation early in life and required a liver transplant was in the mid-30s. So they can keep the native liver for a long time. And then liver transplant is associated with excellent outcomes and a great quality of life. So it takes a village to take care of our biliary atresia patients. Right now, we are 6 surgeons, Doctors Busk, Bonham, Gallo, Melcher, Pham, and me. And we have recruited 2 new surgeons, Dr. Kirchner and Dr. Sasaki, and they have a great deal of expertise with the living donor liver surgery, particularly using minimally invasive surgery. So they'll be on board at the beginning of the year. It does take a village, again, to take care of our patients, anesthesiologists, intensivists, hepatologists, nephrologists, geneticists, consultants, the coordinators, social workers, psychologists, and our referring physicians who become really an extension of our teams. And finally, I'm grateful for the institutional support. There's no question that we need to have the institution rallying behind us. And it's hard to believe that, under all these grapes and all the equipment, we have a little patient undergoing a liver transplant. I'm very fortunate and really grateful to work with such an amazing team. And that's the end of my presentation. Thank you very much. I'm going to stop the screen. If I can figure this out. All right. Thank you.
Thank you. Can everyone hear me? Great. Okay, Dr. Escalante, I want to thank you for the talk. And Josh, if you can highlight Jenny Tice, who is in our audience. She's actually a patient who had a liver transplant 32 years ago. So thank you so much for attending. We're very appreciative and really glad that you're here. And I also wanted to thank Dr. Benson for her great talk on all the new research and things that are going on in the study of biliary atresia. Our next speaker is Denise Alloway, our liver transplant social worker who's been working with our program for many years. And she will be talking about what to expect during a liver transplant evaluation.
Hi, everyone. Josh, could you share my very low tech slide? Thank you. So thank you for the introduction. As Deb mentioned, I've worked with this team for a lot of years, and so have been part of a lot of transplant evaluations, and been asked to speak with you today about the transplant evaluation process. And since every center is a little bit different in the way that they do things, I'll just be speaking generally about what to expect based on my experience with our team. So as you may know, a transplant evaluation is a comprehensive physical and psychosocial workup needed to determine eligibility for placement on the list. So this is a way for the transplant team to really gather information, which will allow them to make the best recommendations for your child's care. So once a referral is placed to the transplant center, insurance auth is requested, and you'll be assigned to a transplant coordinator who will be your point person during that time. During your evaluation, you will meet with a number of people. So you'll meet with a transplant coordinator who, as I mentioned, will kind of be your point person. They can answer program questions. They are the ones that coordinate all the moving parts of the evaluation. They'll meet with you to do teaching and then just communicate with you and the medical team and just kind of make sure everything is done. You'll meet with a transplant surgeon who will speak with you about the actual surgery, the risks and benefits of transplant, what to expect during the post-op period, that kind of thing. A hepatologist will meet with you and do a full physical exam, review your child's health history, talk to you about transplant, what it means for your child, and may make some recommendations for medical management while they're on the list. You will meet with our infectious disease team, get blood work done, if needed, have some imaging studies done, and see other subspecialties like cardiology, hematology. You'll also meet with our nutritionist, our transplant pharmacist, and if it's possible, or if it's a possibility, to speak about living donor. We do have a living donor coordinator as well. You'll meet with a social worker to learn more about, well, we want to learn more about your family, your support system, and kind of help you just emotionally prepare for the transplant process. It's a lot, as you can imagine. And then we'll talk to you a little bit about resources and just things that may be available to you during the process. Our younger patients are seen by a developmental psychologist, and our child psychologists meet with our patients over the age of 5. And this is just to establish a baseline and just kind of further evaluate understanding of transplant and offer mental health support that may be needed. So how to prepare. So since this is pandemic times, I think the first thing is just to make sure you familiarize yourself with your hospital's COVID visitor guidelines. For instance, our hospital does have limitations on siblings and number of visitors allowed and documentation needed to enter the building. So your social worker or coordinator can give you the most up-to-date information on what to expect. Your transplant evaluation may be scheduled through one whole day or could be broken up into several different days. Some meetings could be via telehealth. So just make sure you check your itinerary and so you know where you need to be for each meeting. And if you're coming in from out of town, we can speak with you about lodging options like a local hotel or Ronald McDonald House or something like that. Make sure you bring a notebook or something you can use to take notes. And if possible, bring a second adult. If COVID protocols don't allow for this, you can ask to have a Zoom set up, or if we can FaceTime with the second caregiver. I think you just received so much information on that day that having a second set of ears is super helpful. Speak with your child about what to expect. You know your child the best, so I would say try and explain things to them like at their developmental level and about what is going to happen, who they're going to meet, any interventions that may occur, just so that they're as prepared as possible for the day. Allow your older kids to ask questions and express concerns and feelings around the transplant process. This is their body that we're talking about, and so they're probably going to have a lot of questions. Encourage them to ask their questions and be an active member in the room with the medical team. We absolutely love it when your kids participate in clinic visits. If you have children who are anxious or nervous about a procedure, just let us know so we can bring in our child life specialist to provide additional support for you all. Entertainment and comfort items are also a must. Appointments are long and can be a little boring for kids. So just bring lots of snacks, toys, art supplies, kind of anything you think will entertain your child throughout the day. And then don't forget a charger or headphones, also very important. And then some questions to ask. Bring with you all your questions. We know that your child is unique, and the transplant evaluation is a good opportunity to get most, if not all, of your questions answered. Some questions you may consider are things like, well, what happens once my child is listed? How do I get in touch with a provider if I have questions or concerns? What's a good phone number to reach you after hours? Be sure you have a good understanding about survival rates, risks, and potential complications of transplant surgeries, benefits to transplant, and what you should expect during the postoperative period. What will follow-up care look like? What's expected of me as a caregiver for a newly transplanted child? What kind of apparatus should I expect when they come out of surgery? What does the medication regimen look like? Questions like that. If you were coming from out of town, I recommend you ask how long you should expect to stay locally after your child's discharged. So you can speak with your employer, family members, and just kind of mentally prepare yourself for this time frame. And then think about both the practical and the emotional support that you may need to get through the evaluation, the listing, the transplant, the post-op period. And this could be things like mental health support for you and your family, assistance applying for financial assistance programs, understanding your health insurance benefits, fundraising, or just being connected to another parent who has had similar experiences and can provide support. So I think the good news is not everyone who's evaluated for a transplant actually needs one. So going through this process will give you an opportunity just to learn more about transplant, medical team, and then you'll work together with your team to determine best options for your child's treatment. So that's all I've got. Any
Thank you.
questions?
We'll be taking questions at the end. Thank you. Great. Can everyone hear me?
Yes.
Can everyone hear me? Okay, great. Okay, perfect. So next I'd like to introduce the parents. I'd like to introduce Dr. Lina Al-Rabadi, who's a clinical associate professor of pediatrics and hepatology, who will be moderating our parent panel today. As mentioned, biliary atresia has varied outcomes and different courses for each patient. So we've included 3 families today that are in very, very different parts or transitions or arenas of the care required in biliary atresia. Again, we'll be taking questions at the end. I know we're running a little bit late in time, so if you want to post your questions in the chat, that you can. Please remember Sarah Conlon will be your contact if you'd like to reach out to us here at Stanford Children's Health. So I'm going to turn this over to Dr. Al-Rabadi and our esteemed parents and families. Thank you.
Great. Thank you, Deb. So I'm here to introduce 3 lovely families who are joining us today. Really excited about this second part of this webinar as the families get to kind of give their perspective and give advice to other families who are, coming from the families is really important, in addition to the medical providers. So first, we're going to introduce Anna, who's a mother of 2-year-old Bucky. And Bucky had a Kasai at 33 days of life by Dr. Matthias Bruzzoni, one of our pediatric surgeons. Next, we'll have Mary June tell us about 10-year-old Mason, who also had a Kasai very early in life by Dr. Matthias Bruzzoni. And then last, we'll hear from Lindsay and Mason, parents of 15-month-old Maya, who had a Kasai, followed by a liver transplant at 7 months of age by Dr. Esquivel and Dr. Bonham. I'm going to ask each of them to comment and give us just a few lines about their experiences and their thoughts. I think one of the things that's always astonishing for us providers is how many of these families have never met another family with biliary atresia, and what advice they may have for other families going through this experience, either through a Kasai or towards transplant, and then any other advice they'd like to give. So we can have Anna get started.
I'm Lucky's mom with biliary atresia around, I would say, well, we took him to the pediatrician around 2 weeks. He suspected it. I'll hurry it up since, yeah, so I won't go through all the detail, but 14, low weight, he was back to birth weight. So then we came back today, he was still losing weight. He then transferred us to a nearby hospital who did an ultrasound by blood work after they seen the gallbladder was deflated and the blood numbers were to another hospital, not different one. It was moving a little slow, and we had a liver and transplant unit. Has biliary atresia, she would, if they suspected that, she would bring him to Stanford, because by the time everything came back, we wouldn't have had a Kasai until 2 weeks. We're looking at maybe like 2 months.
Anna, I think you're breaking up a little bit.
Am I?
Yeah, it's better.
Then we,
Sorry, I think you need to move closer to the microphone.
And Josh, can you mute everyone?
Thank you, Anna.
that better. And then, so when we got to Stanford, they did an ultrasound. Dr. Bruzzoni came in, told us he did suspect it. They were going to do a biopsy, some genetic testing. And if we wanted to get the Kasai done Monday, which that would have been, within 3 days of us being admitted, we said yes. We went through with it on September 31st. So he just hit his 2-year post-Kasai. He's followed by Dr. Al-Rabadi. And then just a few things I kind of just wanted to talk about was like 3 things for other parents is just like the process, and just to first is be aware, like know the signs, pale stool. Bucky didn't have that to begin with. He was just losing weight and really jaundiced. Also, like maybe be prepared, have a support system, somebody you can call at any time, because anything can happen throughout the night. So I always have my sister who she knows 24/7, she's up ready to take my other 2 kids. And then just never be afraid to ask questions. Stanford, I didn't know anything. Even the second hospital told us really nothing. It wasn't until we got to Stanford till they just laid it out. And I just want to remember, I know Dr. Arbadi did a podcast. It's really short, but she tells you everything exactly. It's, it's not all medical terms. She explains it really well. The signs, what to look out for, how excruciating it is to get it done before the 30 days. Bucky was only 33, but I know if we would have went to Stanford to begin with, I know it would have been within 20 days of life. I know they would have done it.
That's amazing, Anna. Thank you so much for saying those words. Mary June, would you like to go next?
Sure. Can you hear me?
Yes.
Okay. Well, so Mason, actually, he's almost 12 years old. So he had the Kasai 12 years ago in April at Lucille Packard. And we are just so lucky that we live where we do, because we were, he was somewhere between 6 and 8 weeks old. It's all a blur now because it was so long ago. And so overwhelming when everything happened, but he was, I don't even think he was jaundiced, and his stool was pale, but I didn't catch it. I completely missed everything. And then luckily my parents and my in-laws thought he looked jaundiced, and they took him into the pediatrician. They did a blood draw, thank God, and found he was in liver failure. And he was transferred to Lucille Packard that day. And they did a liver biopsy, I think the next day. And he had a Kasai probably 3 days after everything started. And it was all a whirlwind. He was up and down the first 2 years of life with cholangitis, getting admitted to Lucille Packard, going on an IV to get the infection under control. And we have just, since he was 2, been so lucky because he has been thriving. He's a crazy, wild, active kid. He still takes all of his medications, which makes things a little bit, but it's just been, Packard was a godsend. Dr. Bass and we had the same surgeon, Dr. Bruzzoni, who was a godsend too. But everything was a big blur. But the thing I want to say is don't Google, to tell parents is don't Google. Talk to your doctor, because everybody is so different. And you don't want to read crazy stories on the internet. And then I think they're going to post, there's a link, because I could go on for days and months and on about this, but
The link is posted. Yeah.
the
it's
link
in
to
the chat.
the blog, thanking the doctors at 10 years for everything they did. And then this is amazing because, again, 12 years and I've never talked to or met anybody who had a child with biliary atresia ever. So the girl that's on here, Jenny, that's just amazing. She should have a blog. And because she's the expert. She went through it. So, and my son, if he ever asks questions, he doesn't even know there's anything going on except that he has a big cross on his stomach. So I would hope to reach out to somebody like her who has actually been through it. So again, I can go on and on and on. But the advice too is the future is bright because Mason is a crazy wild kid and doesn't think anything's wrong with him.
Perfect. Thank you. It's such a powerful story. And then we'll let Lindsay and Mason tell us a little bit about Maya.
This is Maya. She is 15, 16 months. And in January of this past year, when she was about 7 months old, we had our liver transplant. So like everyone else's story, we had our Kasai at 64 days of life. And, the next few months, we were just like crossing our fingers, hoping that it would work. And we got a referral a little earlier than they let us. We went around 2.5 months to Stanford after doing our research and really thinking this was our best bet to getting a transplant and a good transplant. And thankfully she needed it and we were already plugged into the system. We got a bunch of the resources that everyone mentioned. That was just a godsend. Started our liver, like the living donor workup. We got her listed and I think it was really quick after we got listed, like maybe a month after listing. And this is in the COVID time, so that might have been different, but we got an offer like a month after getting listed. And why don't you tell the other part?
Yeah, so after we got listed, it was kind of a nice relief. We had a chance to something to work towards. It was still a lot of work, a lot of imaging and kind of running around that needed to be done on our end, but we had great support from the pre-transplant coordinators and the transplant team down at Stanford. So we got one call and went down to Stanford, and unfortunately Maya's lungs were a little wet for the procedure. She wasn't ready for it. So we got her kind of tuned up there while she was there. And went back home, and only 10 days later got another offer. And this second offer was a perfect fit. It all really worked out. In the end, she had a short hospital stay, really, only about 10 days or so. We weren't able to get in at the Ronald McDonald House. So we got an Airbnb locally, and only ended up needing to stay local to Stanford for about 6 weeks or so. And, you know, lots of meds and minor challenges at the beginning after transplant, but all much easier than her condition before transplant. And she quickly came off the meds. We got home, you know, relatively quickly and reunited as a family. And it's honestly, you know, been a great time in our lives, really, all things considered.
Well, we remember the first time she opened her eyes after the surgery, and that's the first time we noticed that they were like, her sclera were clear white, and she was just, her appearance just looked so different from after the surgery. And then it just got better and better from there. Like, we learned her personality. I know she's only one, you know, but she's so much different than my son. We're just so glad we can be there to see her grow up and she's healthy. There's always anxiety, like every lab draw, we're like, is it gonna reject? But we couldn't, like, Stanford has been such a pivotal part to our family, and like the most memorable part, obviously, of our lives and her life. So we just would want to give back and try to let everyone know that we're here for questions, and we went through it. We were the one that failed, or Kasai failed, and that happens, but we couldn't have asked for a better team. And luckily, she's not going to feel this pain when she's older. She won't remember it. So that's one of the good things about having it done early.
That's so amazing. I guess one of the things whenever we sit down and tell a family that their child has biliary atresia, it's very stressful. It's very lots of anxiety. What do you guys think was the most helpful, or how did you get information regarding biliary atresia? Did you find it most helpful asking your medical providers or your team, or did you look elsewhere? What advice would you give for families regarding that?
For us, you know, we found a lot of decent information on the internet, targeted at Stanford and Children's Hospital of Philadelphia. Those are some of the best resources for us.
And then I think another question that I think would be helpful for families is that, you know, we really aim to make the diagnosis of biliary atresia early and get kids to Kasai. But we do know, despite everything, there are patients who will progress and go towards liver transplant. So we're always trying to kind of tell families, you know, liver transplant sounds very intimidating, but as we heard in Dr. Esquivel's talk, you know, these children still do very well, and graft function and survival is really wonderful. So is there any advice you would give towards families whose patients have had a Kasai and they're not at a place at transplant yet? But did you think it was more intimidating than it you know, played out? Or
yeah,
what?
I mean, I was so nervous. Like whole, no one in our center wanted to talk about transplant. Even our pediatric GI didn't want to do that. So I wanted a referral just so I could like get the information, know what the next step is. There might be a chance we might not need it, but I think just talking to someone was very helpful. And then know that your child, although there are some challenges with immunosuppression, I mean, we're worried about that her whole life, but it's just like giving them another chance, a whole nother life. You're not going to get the ascites, you're not going to get the varices, and you want to obviously get the Kasai as late as possible, but it's not the end of life. Like, this is, especially because we were actually had a date for a living donor, and we thought that was our savior, and we were just like counting the days to our living donor because we couldn't go anymore. And so for us, it was very obvious, like as a family, we just couldn't function any day longer. And so really it was just a godsend. I guess I would just say that we're so happy. Like, the transplant coordinator, Kat, is our transplant coordinator. We like can text her or email her, and like within hours she'll email us back. It's just seamless. Like, any sort of stupid question we have or like little worry, she'll look into it and she'll like And I think we don't feel bad bothering the doctors because we have someone there always available for us. It's very anxiety provoking, but you're in a really good place. If you're with this team, it's the top. There's so many resources out there. We did apply for like a living, like a grant for your housing when we were in the hospital, and we were not able to, we had to stay local. So we had to pay for an Airbnb. But I would just look into all that kind of thing. Think about what your work situation would be, what your family support can be, because that was very anxiety provoking for us. Like, what do we do when we get the call? Who do we call? What's the plan? But thankfully we're able to get through it.
That's amazing. I really thank you three families for sharing your stories. They are very powerful. I hope they encourage other families. It's really great to see families, connect together and really tell their stories. So thank you for your time. And then we can address any questions that Sarah may have come up during the chat, or if there was anything else anybody else wanted to say.
Thank you. That was great. Sarah, are there any questions so again, just want to thank everybody for staying on and our technical difficulties. We apologize. But again, Stanford Children's Health, our program caring for patients with liver disease and transplant, we really think is a good option. And if you have questions and want to be seen here, we hope that we can facilitate it. We have an international audience. We have someone from Argentina, someone from Saskatchewan. So this has really been a great event. And Sarah, are there any questions that came up in the chat?
Yes, we have two questions. One parent asked about her son, who is 3.5 years old. During his first 1.5 years of life, he was in and out of the hospital with cholangitis quite a bit. And since then, he's done better and not had the cholangitis. And so she has two questions. Number one, do we know if cholangitis hurts? And number two, do we think there's something that as the kiddos get older, does their immune system strengthen, and does that help fight the cholangitis?
I think that's a great question. So as we saw with Mason's experience, that he had cholangitis more often early on and then has gone for years without an episode. Sometimes as kids get older, you can have less cholangitis. The risk of cholangitis never 100% goes away. So it's always important to look out for signs, for unexplained fevers, jaundice, or other symptoms. But it can get better as you get farther from your Kasai, and as you grow, and those bile ducts potentially can grow. So it can get a little bit better. I have heard, I don't know if anyone here has had cholangitis and would want to share, but I've had patients tell me that you can have right upper quadrant pain, so pain kind of near where your liver is at the time, but it just usually gets much better with treatment. And sorry.
Yes, Carlos, I can make a comment about the cholangitis, because the new kind of evolving recommendation is that during the first year after doing the Kasai, that the children be placed on antibiotics, prophylactic antibiotics for a year. Because the cholangitis is an infection, and it's an inflammation, and that could predispose to more injury to the bile ducts and to scarring. So in the past, they used to use steroids, trying to minimize that. But the interesting thing is that when the Kasai works, when the jaundice goes away, those are the kids that are more at risk for having cholangitis, because they have a system that allows the bacteria to go from the intestine up into the liver. So this is kind of an evolving thing, but I agree with Dr. Benson. Over time, the frequency of cholangitis decreases in the majority of the kids. The other possibility is to use also deoxycholic acid, which makes the bile flow better. Although in terms of the science, it's not very convincing, but that's something that we use quite frequently.
Sarah, any other questions?
Yes, and then we had another question about the side effects of immunosuppression in general, and then as kids head into adulthood, what to look out for if they're taking Prograf or Cellcept or another immunosuppressant.
I can start and then I'll let the hepatologist weigh in. Most of the immunosuppressive medications do have side effects. At the beginning, patients do require higher doses, but as time goes by, they begin to accept their transplanted organ better. And so we try to taper the medications to minimize the side effects. But we watch the blood pressure, the sugar in the blood, and also the function, the kidney function. When they are adults, especially women, if they want to get pregnant and have babies, then we try to eliminate the medications that could pose a problem to the baby. And basically those medications are like the Cellcept or mycophenolate and the other ones, sirolimus and everolimus. But tacrolimus, Prograf, and cyclosporin, those are okay as maintenance medications if they want to have children.
Thank you,
Go
Dr.
ahead, Sarah.
Okay. I see a question. I think there's some specific, maybe specific questions to people's children. I guess in general, do the hepatologists have a recommendation about how long patients are typically on Actigol?
Yeah, I've seen a few questions about how long to take Ursodiol or Actigol and about how long being on antibiotics. There's a lot of variation because there isn't great data on how long those, about how long to give them or clearly saying this is the time to stop. So I think there's a lot of variability in different practice about how long people stay on those medications. But for sure with antibiotics or probably both medications, if people have infections or have bile lakes, I saw someone mention that also in the chat, which is just an accumulation of bile in the liver that can increase the risk of infection, that it'll vary. So your treatment team will probably have different recommendations depending on the specific situation of your child. So it's a little unclear. Yeah. Yes.
I was just gonna, can you hear me?
Yeah.
Mason, he's the one that he's almost 12 years old, and he's Actigol and ciprofloxacin still for almost 12 years. So I don't ask questions about the future, but I guess someday they'll have to take him off the ciprofloxacin.
Mm-hmm. And I think again, it varies. Sometimes some people will come off antibiotics and be off antibiotics in the long term. And as you see, sometimes antibiotics are on for a longer period of time. Again, it's kind of the combination of factors that seem, tailored to each kid.
There's another good question. A parent would like to know if there's any foods that are good for the liver or foods to avoid for liver health.
That's a great question. So in general, healthy food, healthy eating is great for the liver. And we want, it's very similar to more general recommendations about eating, fruits and vegetables, whole foods, limiting processed foods and lots of sugars. We also think about that we want to do everything we can to keep there from being additional separate injury to the liver, like from fat in the liver, or things like that, or from, from drinking, from alcohol, as people grow up into adulthood. We also are nutrition is very important. It's something that we keep a very close eye on. And we also think about vitamin levels. And so it's not uncommon for our older kids with biliary atresia, or either as babies or as we grow up, to have low vitamin levels, especially things like vitamin D. So checking on those periodically and taking vitamins or supplements if needed. That can come up in our post-transplant kids as well, but tends to be a little bit more in kids with biliary atresia who have had a Kasai, but not a transplant.
There's some more questions regarding the antibiotics. I think a lot of the parents are asking about the antibiotics. Again, as Dr. Benson said, it is really patient specific. In terms of other organ damage, it's mostly like, is it indicated for this patient and for how long? So that's the one thing, how it's patient specific. And the second would be, it's just antibiotic resistance. So patients will need these in their lifetime. So using them unnecessarily is kind of what we think about. And then in terms of like recurrent cholangitis, in some situations and not all, but that's what you should discuss with your providers. It can be an indication for transplant, and you can think of transplant earlier if a patient is having recurrent cholangitis despite antibiotic prophylaxis and so forth.
Sarah, I think we'll take 2 more questions to be mindful of everyone's time since we've gone over.
There's one question that's come up twice, and I apologize. I'm not sure if it was on Dr. Esquivel's slide deck or Dr. Benson's. There's a question about the slide about success rates of transplant and why was the success rate a little bit less in the biliary atresia patients?
And that's for you, Dr. Esquivel.
A little bit less in regards, in comparison to what?
I think Dr. Esquivel, you had it in comparison to metabolic liver disease on that slide. So I think that's what the family was asking.
Yeah, well, it's a different underlying disease. But actually the results are quite similar. So if you compare them statistically speaking, there is no difference. That would be the answer.
Great. I think that is all the questions that I have seen come through. I think we addressed them. And if we didn't, I apologize. Please send me an email or continue to text in the chat and I'll write them down and I'll email you back.
I just wanted to wrap up and thank our speakers, our parents that participated, our help from marketing, help from Josh with his Zoom expertise. We hope that this provided education for you that allows you to help care for your patient, your child with biliary atresia, and that it's provided support and education for you. And we hope to do this again. So thank you all for giving time on your Saturday afternoon, and have a great rest of the day. Go Giants.
Thank you.
Thank you.
Thank you.
Thank you very much.